Welcome to our International Papillomavirus Society educational webinar series, and I'm delighted to introduce you to our topic today about managing HPV positive women. What is next and how do we triage after an HPV test? So today we'll be covering triaging strategies after a primary HPV screening, considering the best algorithms, technologies and approaches for triaging, for screen, triage and treat approaches. And we'll also be explicitly considering strategies for high-income countries and considering whether strategies might be different or similar for low and middle-income countries. So this is really timely. As many of you watching will know, it's 1 week since WHO launched their updated guidelines for cervical screening. And this has really been based on the emergent evidence, the strong evidence that HPV screening is more effective than either cytology or naked visual inspection after the application of acetic acid. And so many countries have switched or are in the process of switching or implementing validated HPV assays for primary screening. However, there is a challenge about how to triage HPV positive women, and this session will really dive into that topic in detail. So my name is Karen Canfell. I am director of what's called the Daffodil Centre at the University of Sydney, and I'm an epidemiologist and modeller, and I've been one of the people involved in supporting the development of the elimination strategy and modelling its impact, and also supporting the development of the WHO guidelines with modelling. Just to tell you a little bit before we start about the International Papillomavirus Society. It is the global scientific authority on papillomaviruses, and our mission is to contribute to the elimination of papilloma-related diseases, cancers of the cervix, as well as anogenital tract, generally in males and females, and also in head and neck cancers. So IPV strives to facilitate both research and translation of the research results into new clinical applications and public health policies. We promote and support education about papillomaviruses and career development in papillomavirus-related research. And also to know that IPV has launched the HPV Hub, Connect, Collaborate, Advocate, an online knowledge-sharing space for HPV advocacy and awareness. And our members come from more than 50 countries and have expertise that's multidisciplinary across epidemiology, genetics, virology, oncology, biology, gynecology, and public health. And to join IPV, you can sign up with the QR code on the. So I'd like to move to introducing our distinguished panelists. Firstly, Dr. Marc Arbyn. Marc is coordinator of the Unit of Cancer Epidemiology at the Scientific Institute of Public Health in Brussels and a guest professor at the University of Ghent. He's also the representative of Belgium in the Scientific Council of the International Agency for Research on Cancer. His unit, the Unit of Cancer Epidemiology, is specialised in synthesising evidence regarding application of new methods in the field of prevention and treatment of HPV-related pre-cancer and cancer. He's the author of over 300 peer-reviewed papers, so well known to our community as the guru of meta-analysis in HPV. He was editor-in-chief of the second edition of the European Guidelines in Cervical Cancer Screening and PI of several international fora dedicated to test evaluation. Our second speaker and panelist is Dr. Marc Schiffman. Dr. Schiffman has studied human papillomavirus and cervical cancer at the National Cancer Institute in the US for almost 40 years. He's well known indeed as the godfather, if you like, of HPV epidemiology. His natural history studies gave rise to translational research on HPV tests, serology, cytology, colposcopy, histology, and vaccines. With Dr. Nicholas Wenchinson, he's the principal investigator of the Cancer Cures Moonshot Initiative, which is called the Accelerated Control of Cervical Cancer. And his current priority is to validate screening methods and strategies, including self-sampled HPV typing tests and deep learning approaches to classify cervical images for resource-limited settings. So I'm delighted now to hand over to Dr. Arbyn for his lecture. Thank you.
Thank you, Karen, for this nice introduction. I hope you see my screen.
Yes, all good.
So thank you for the invitation to discuss today with you triage of HPV positive women. I have received from the Papillomavirus Society 3 questions, and we should try to answer them. The first was, when do we need a triage strategy after having introduced screening with HPV? What are the best parameters for a triage strategy? And third question, are strategies for low and middle income countries different from those in high income countries? So I can immediately start. The first question, when do we need a triage strategy? In a screen and treat strategy with ablative treatment of all eligible screen positive women, no triage is offered. Such a strategy is recommended by the WHO. It might be useful for low-income countries in particular, where the philosophy is do not miss an opportunity to manage screen-positive women. A triage strategy is an intrinsic component of HPV-based screening policies in high-income countries. And here the philosophy is restrict treatment to those who need it. But to do triage, we need an accurate and affordable test, and this test must be available. Second question, what are the best parameters to triage for a triage strategy? There are two parameters I propose. First is the risk of pre-cancer, CN3+, if women are triage positive. The second, the same, the risk of CN3+, if women are triage negative. The first parameter is nothing else than the positive predictive value. And this positive predictive value should be sufficiently high to have an efficient triage. The risk of CN3+, if women are triage negative, corresponds with the complement of the negative predictive value, CNPV, 100% minus negative predictive value. This CNPV determines the safety of the strategy. It should be as low as possible. If the PPV is sufficiently high, then the triage is efficient and justifies management, further referral and treatment. If the risk is sufficiently low when women are triage negative, then the women could be released back to less intensive screening. Now the utility of whatever triage strategy can be visualized in a PPP plot, and I will explain later what that means. Well, we have conducted a meta-analysis, and the motivation was that we know, all of us know, that HPV is more effective than cytology screening, but HPV screening identifies more women that are screen positive. And we can limit the potential harms associated with HPV screening and finding more women as screen positive by using validated HPV tests that show a balance between sensitivity and specificity, not to screen young women, to screen with longer intervals compared to screening with cytology, and of course, by using appropriate triage strategies. To deal with that, we conducted a meta-analysis on triage of HPV positive women. We considered several accuracy outcomes, also the predictive values. These predictive values were also computed considering different background risk using Bayesian formulas together with the pooled estimates of sensitivity and specificity from the meta-analysis. Altogether, we could find information from more than 50 triage scenarios where women were triaged at the baseline reflex testing at time 1, often called reflex triage, with or without a second triage at time 2, when women were triage negative at time 1. We included a multitude of tests and combination of tests, cytology at different cutoffs, HPV typing, restricted or more extended, RNA testing, viral load, HPV retesting, testing for protein markers, methylation markers, visual methods. We did 2 meta-analyses, one on triage of HPV positive women on a clinician taken cervical sample, and another one where HPV positivity was defined on a self-sample. So as usual, we defined the PICOS criteria, so I will not develop further on this. We could include, considering the literature, up to early 2020, we could find 94 studies that provided information. And for the period 2020, we added 6 new studies, but only on triage with P16 or dual staining. Overall, the quality of included study was very heterogeneous. But let's now give some information on the pooled accuracy estimates of one-time triage strategies, called also reflex triage. The most documented triage method is simple cytology, and I give here the forest plot for the sensitivity of cytology at cutoff ASCOs for outcome CN3+. The pooled sensitivity for more than 30 studies was 78%. The pooled specificity was 73%. There's quite wide variation in the accuracy. So here we have the summary of the forest plot in the previous slide for outcome CN3+. We also developed it for CN2+, where the pooled sensitivity was 72%. And you see here the confidence intervals. The pooled specificity was 75%. We found a remarkable discrepancy for the level of knowledge of the cytologists regarding the HPV status of the women that provided the slide. When the cytologist was aware that he was looking at a slide of an HPV positive woman, the sensitivity was remarkably higher, but at the expense of a serious loss in specificity compared to cytologists. These are the red curves and points where the cytologist was not aware of the HPV status. Of course, in the context of triage of HPV positive women, we will be more in the blue situation. Now, of interest for low-income countries, we can triage with visual inspection after application of acetic acid, abbreviated VIA. You see here the meta-analysis using a forest plot. The outcome is CN2+. The pooled sensitivity was 61%, specificity 80%, but remark the very wide scattering of estimates, both for sensitivity and specificity. This was for outcome CN2+. So we also, you see here the summary rock curve corresponding with this forest plot. We also did the meta-analysis for outcome CN3+. Here the pooled sensitivity was 66%, with values ranging from 9 to 91%. So an extremely broad variation. The pooled specificity was 79%, with also a wide variation. Now, I must acknowledge some doubts in the credibility of these pooled sensitivity specificity estimates, and this is based on another meta-analysis where we pooled the accuracy of VIA in the context of screening, and this is now being covered by my colleague Imani Afar in a Cochrane review. She was able in a few studies to distinguish the type of gold standard verification, where we have in blue independent verification with random biopsies on top of colpo-targeted biopsies, and in red we have studies where biopsies were targeted based on colposcopy. And visual screening via is visible, uses acetic acid, colposcopy also. So by the correlation between the gold standard and the test, we can have a serious inflation. And we see it here. The sensitivity was in the blue studies was not higher than 50% pooled, with values even going down to 40%. In the studies where biopsies were targeted according to colposcopy, the sensitivity was of the order of 15 to 20% higher. So it's possible that our meta-analysis on the accuracy of VIA in the triage setting might have suffered from the same misclassification, gold standard misclassification, as in screening. We also pulled the accuracy of triage using P16 immunocytochemistry or double staining, which also looked for overexpression of Ki67. And we compared it with cytology at cutoff ASCUS, which I have shown in previous slides. So in blue, we have the immunocytochemistry here for Alcom CN2+. And we see that the sensitivity is higher, 30% higher for Alcom CN2+, for Alcom CN3, 9% higher. And at the same time, there is also a gain in specificity, and this is also statistically significant. Now, a very new finding published by Nicolas Wensensen in the GNCI 2 weeks ago. He looked for the accuracy for automated interpretation of slides that are dual stained for the proteins P16 and Ki67. And he found that this dual staining, defined at a cutoff of 2 positive cells, was similarly sensitive when compared to cytology or dual staining with manual interpretation. You see that unity is included in the confidence interval, so the relative sensitivity does not differ significantly from unity, whereas the relative specificity is higher than unity. So automated interpretation is more specific than manual interpretation, and is also more specific than simple cytology triage. So these types of meta-analysis we have done on a long series of individual tests and cutoffs, and we summarize here the pooled sensitivity for CN2+, sensitivity and also specificity. For CN3+, we pull here the sensitivity for CN3+, not the specificity. We have already discussed simple cytology, visual inspection, cytoimmunochemistry. What I did not yet discuss was triage with just genotyping, restricted genotyping for type HPV 16-18, where the sensitivity is quite low, 53%. Specificity is good, but the sensitivity is too low to considered as a safe single test triage method. Here at the bottom we have 2 combinations, restricted genotyping in combination with cytology, which is done if only other high-risk HPV types are present. This yields good sensitivity, but lower specificity compared to the best single test triage methods. The combination of HPV 16/18 and VIA, if only other high-risk HPV types are present, gives good sensitivity and not that bad specificity, but we had only 2 studies, so the level of confidence is quite low. And I refer also to the possibility of gold standard misclassification that I discussed before. Now, a few examples of 2-time triage strategies, which means that we add after a first-time triage, for instance here, a triage algorithm used in the Netherlands currently, where they do reflex cytology at cutoff ASCUS, and if it is negative, 6 months later, again, cytology is offered. This has good sensitivity and a good specificity. Here, a method applied in Italy, for instance, where at the second delayed triage step, high-risk HPV testing is done, same test as the screening test. This yields very high sensitivity, but substantially lower specificity. And here we have combinations of genotyping and cytology followed by a second-time triage. We always have here high sensitivities, but be careful. We have here right censoring. The sensitivity is certainly inflated by lack of follow-up of the triage negatives. And we should need here a second screening to have a full appreciation of the longitudinal sensitivity here. Now, a few examples of recommended triage algorithms which are in place in studies in countries that have already introduced HPV screening. Here, an algorithm which I already commented upon, applied in the Netherlands. The other one applied in Italy and France. Both are recommended in European guidelines. In the first algorithm, reflex cytology is offered at cutoff ASCUS. If positive, women are referred to if the reflex cytology is positive, women are referred. If the reflex cytology is negative, repeat cytology is offered 6 months later. And if positive, colposcopy, and if negative, women can go back to routine screening. In Italy and France, the other recommended European triage policy, which is the same at the beginning, but at the delayed triage, the late triage is offered at 12 months. And here, not cytology, but high-risk HPV testing is done. And if women are still HPV positive, they will receive colposcopy. If negative, they are referred back to routine screening. A more complex triage algorithm, which is in use now in Australia, that introduced screening, HPV screening a few years ago. The first step, reflex triage step, is in fact included in the HPV test based on restricted HPV genotyping. If women are carrying 16 or 18, you're referred to colposcopy. If they only carry other high-risk HPV types, they will receive cytology. If the cytology is high grade, means ASK-H positive, they will receive colposcopy. If they just have low grade or negative cytology, they will have repeat testing 12 months later. And then 12 months later, the same algorithm is applied as at reflex triage. Women that have 12 months later they are carrying just other high-risk HPV types and have low-grade or normal cytology, they will receive a third triage at 24 months after baseline screening. And if positive, the women will have colposcopy. If negative, they can go back to routine screening. Now, the algorithm recommended a few years ago in the US also starts, as in Australia, with HPV 16/18 genotyping. If positive, colpo. If only other high-risk HPV type reflects cytology. This is the same as in Australia, but here the cutoffs for positive cytology are lower. All women that are cytologically abnormal will have colposcopy. Women who have normal cytology, they will have repeat testing 12 months later, and they will then be further managed according to risk-based guidelines. To be noted is that FDA has now approved dual staining and also HPV testing with extended genotyping, and algorithms are now being revised, and probably we will see new guidelines in the coming months. Now, the last algorithm is in high-income countries, the one in England, where they start as recommended in Europe with cytology. If positive, colposcopy. If negative, co-testing at 12 months. If the co-testing is, if the women are high-risk HPV negative, independent of the cytology, they have routine screening. If women are high-risk HPV positive and have positive cytology, colpo. If the cytology is negative, repeat testing, with then just only high-risk HPV testing, with those being persistently positive referred to colposcopy, and those who have cleared the virus are referred to routine screening. Then finally, a triage algorithm that might be considered for low-income countries starts with considering the genotypes. 16/18 can have immediate treatment with ablative treatment with thermal or cryoablation. If they are just carrying other high-risk HPV types, they could be offered triage with VIA. If this VIA is positive, they can be treated if eligible. If VIA negative, they can be offered a next screening, or they could have a second triage visit. Now for the future, and Marc Schiffman will tell us more about, we could consider combined genotyping combined with portable colposcopy. Now, I would like to introduce you in the concept of pre-test, post-test probability plots. I repeat what I was saying here in the beginning. A triage method, we can consider it as efficient if triage positive women have a high risk of pre-cancer which justifies referral. If the triage is negative and they have a risk that is so low that they can be referred to back to routine screening, we can consider this triage pathway as safe. And we use the PPP plot to visualize. In the PPP plot, we have a pre-test risk at left and a post-test risk at right, going from 0 to 100%. We consider risk zones, which suggest what to do if a woman has a risk localized in this risk zone. Red means, referral is justified. Green means it is safe to release the patient. In between, we have the yellow zone, and here it is useful to do some further testing with the purpose to distinguish women that can be referred or women that can be released. We refer to a publication of 2018 in Annals of Internal Medicine, where I explain the principles of the PPP plots. We have applied here some Chinese screening and triage data. Here we have triage with just simple cytology. Chinese women in the database had a pre-test risk of CN3 plus of 7%. If ASCUS plus, this increased to 14%. They were in the red zone. If NILM, the risk was 2%. They are not really safe yet, so further testing is recommended. We can also use a combination of 16-18 and cytology. Women 16-18 positive have a risk of 27%, can be referred. Those with other types, if cytology positive, have a risk of 7%. To bring the women in the red zone, low cell cytology cutoff could be considered. If they have NILM cytology, they are in the green zone, suggesting that they could be referred back to screening. So these are simple risk zones with just 3 levels. In US, they have considered 6 risk levels, with at the bottom a risk which is lower than 0.15%, very low. Here, women can be screened every 5 years. Then in green, women can be screened over an interval of 3 years. In yellow zone, women should be retested. In the orange zone, women are referred to colposcopy, and then further women should have biopsies or even have direct treatment. We have plotted here, assuming an underlying pretest risk of 9%, and we apply restricted genotyping followed with cytology. Here are the women that are HPV 16-18 positive. They should have colposcopy. They are in the orange zone. If they are carrying other types, they can have cytology. If positive, a colposcopy is justified. If they have NILM, 12 months later, we can do again a high-risk HPV test. If it is positive, they can be referred to colposcopy. They are in the orange zone. If they are cytology, if they are HPV negative, they are in the green zone and they can be retested 3 years later. Here, the PPP plot, where we use the data from our meta-analysis on a high-risk population with an underlying risk of 17% of CN3+. In fact, you're already in the red zone. We could consider to treat them all, or we could also use 16-18 triage if positive for these types. They have a risk of 36%, justifying treatment. If they have other HPV types and they are VIA positive, they can also be treated. If VIA negative, they still have a risk of 3%, and still further testing would be justified. Here we have a combination of 16 and 18 genotyping with dual staining, which we are currently discussing with WHO for second level triage recommendations. We have here first the bifurcation 16, 18 positive women are here, HPV negative women are there. We can consider dual staining in both situations. If women are double positive for dual staining and for 16-18 genotyping, they have a risk of 31%, justifying further referral with certainly biopsy taking, not just colposcopy, even treatment could be considered. If they are double negative, rescreening in 3 years. And if they are discordant positive or negative, further testing or colposcopy could be considered. This is open for discussion. So we can conclude that there are multiple acceptable options. If we only look at the one-time tests, or combinations, we can identify immunostaining for P16 and Ki67, and also the combination of low cell plus cytology with HPV-16 identification. We see for the strategies where we have data on a second time triage, that these 2-time triages are more safe, but this generates more tests, follow-up visits, and compliance with a second triage is crucial here. The triage applied in the Netherlands, twice cytology, was okay, but it suffers from right censoring, and we can only recommend that for countries with excellent local cytology. Cytology at the beginning and high-risk HPV testing 1 year later, if women are cytology negative, is safer than the Dutch triage, but it requires more referrals. Promising triage methods or involve the use of methylation markers, but we had few studies that we could pool, and this was due to the fact that methylation is not just a test, it's a family of tests. There are many methylation markers. But a clear advantage of methylation is that it can be easily performed on self-samples, whereas cytology and immunocytochemistry are difficult on self-samples. Now, for decision makers, the choice should be defined by the background risk. Right today, we have to take into account the age, the HPV vaccination status, the screening, previous screening history, the available resources, the availability of tests, and very important, the applied benchmark, the risk benchmarks. For low-income countries, Marc will tell us more about this, but I would recommend already HPV testing with a point-of-care test on self-samples, triage on the spot, with maybe a combination of genotyping and portable colposcopy. I leave it to Marc to discuss this in more detail. Just a few suggestions for future research and actions: pooling of individual patient data from national screening databases, time to even statistical methods to look for longitudinal data. We look for evidence of the performance of portable colposcopy devices, and we will need validation criteria. The VALCO project will deal with that. We have many triage options. We have to update them continuously, and WHO has assumed the role to do that and to update in vivid guidelines and incorporate evidence as soon as it is available and established. A challenge is to define locally defined risk-based decision thresholds, and this is for Europe. Given the fact that we have now primary screening, we have so many screening tests and triage methods, we have to update of our European guidelines. Now I come to my third question: triage in low and middle income countries, in particular low income countries. And I invite Marc Schiffman to tell us more about this. So, dear colleagues, I thank you for your attention, and I give the word to you, Marc.
Thank you, Marc. Very, very good, as usual. I've been working on international health, meaning for me, coming from the United States, trying to invent for low resource settings, because I believe that there should be health equity regardless of setting. And I'm very interested now at the end of my career in figuring out what we can do from the IPVS community to increase equity and to basically bring HPV-based prevention of cervical cancer and related cancers to everyone. So Marc's talk was timed, as we've said, as Karen said, along with the WHO recommendations for screening and treatment, which was just released. I found it to be very much oriented more towards high income options. And my main concern is, what if there are limited resources, particularly with COVID impoverishing and distracting public health and making us even more conscious of limited resources. It takes a long time to invent and for these expensive technologies to become affordable, if ever. And so the call for elimination to me means that we're going to need more invention of strategies specific for settings in which cervical cancer cannot command very much spending. And it has to be almost so simple that it can't be ignored, because I'm afraid that cervical screening will drop off the list of priorities. So if we do go to self-sampled HPV testing, we, I believe, need affordable, accurate triage because HPV negativity allows us to safely, with a self-sample, tell most women that they're fine, to reassure them, and to bring to clinics that might be crowded and hard to get to, only those people who are HPV positive, in which we can try to find and treat precancer in order to prevent cancer. It's the treatment that matters. The new WHO guidelines say triage is optional, that it could be triage or don't triage. I think triage is important because in the low resource settings, HPV can be extremely prevalent. All health decision models have these models underlying them of what happens on the way from normalcy to cancer. If HPV is very, very highly prevalent, then treating all women by common sense really is going to be very difficult. And there's a lot of reasons to expect that not all those women need to be treated, and it could be a lot of overtreatment. So if we look at the mentioned options in the WHO, then we have HPV typing, which is very useful, especially if extended, but it's not widely available. We're going to try to make it widely available and inexpensively so. Cytology is a very good option, but it's not widely available. We would need to improve its availability in order to use it. Colposcopy biopsy is excellent if it's very well trained, requires good training, but it's not widely available. And VIA, we need to improve its accuracy because it's not very reproducible nor accurate. A return visit is often not an option in places where we only have 1 or 2 times per lifetime to reach people. So we're interested in our project, which is a moonshot project, to try to bring forward self-sampled HPV testing yielding HPV grouping. We think that this is very important, to use more HPV extended genotyping, because it's our best marker of what's going to happen in the future of risk. And we're using artificial intelligence on mobile picture devices, image capture devices, and we're bringing that forward as an assistive technology for health workers so that we can have VIA and it might be more accurate and reproducible, and mobile treatments. And so I don't recommend any particular technique or method or product, but we think self-sampling is going to be very important. We know that the extended genotypings, we believe, is very important. Just based on the percentages of cervical cancers worldwide, we know that 16 is different than 1845, and that these 16 related types in the alpha 9 species group are very important. And so we are looking to use this knowledge to also indicate some of the IR positives for carcinogenicity that are not as important. And we are adapting our methods to smartphones or to dedicated devices. In other words, we are trying to get an option where a self-sampled HPV positive woman comes and can be triaged by a health worker using her own VIA impression and also an assistive opinion from a device that's inexpensive. And that, combined with simple mobile treatments, we believe can be something that could make it much faster than the current projections to control cervical cancer in those places most in need. So what we're doing is a whole package. There's going to be a symposium on it. There's many, many topics that are related to HPV to discuss. It's complicated, but in its final practice, it's simple, accurate, and inexpensive. And we believe we need that because we don't see that the current recommendations allow for good options for low-income countries. In conclusion, we believe that we still have a couple years of work until we have something, despite the pandemic. And we plan within a couple years, we're going to start the studies, quite large studies next year in many countries. And then we hope the following year to have a handoff that goes along with one-dose vaccine for control in low-income countries. Thank you.
Thank you very much indeed to Dr. Arbyn and Dr. Schiffman. And we're now going to move to a moderated Q&A panel session. So thank you very much. Those were wonderful presentations, giving us, I think, an update on the latest evidence on triaging and considerations in developing new models of care particularly for LMIC countries. So just to kick us off, we've had some questions come through on the chat, and I'll try and summarize a couple of the prominent issues coming through. I think that if we go first to you, Marc Schiffman, I mean, we all have so much hope, I think, for HPV self-collection as a true game changer in developing viable models of HPV screening delivery, or indeed cervical screening delivery in LMIC in particular, in resource-limited settings, and indeed in high-income settings as well for underscreened women. And, you know, as you've just covered, it does pose a unique set of challenges for triaging. We do have potentially the option of partial genotyping or extended partial genotyping, the potential future of methylation or AVE, as you've said. But what do you think countries that are considering self-collection options should be doing right now on the ground in the next couple of years? WHO has released a couple of models of suggested algorithms. One of those is screen and treat with HPV. You know, and other models use partial genotyping. How would you suggest that countries approach this as they really try to get on top of how to scale up HPV screening and self-collection in particular over the next year or two?
Several times I've been overly optimistic, and I regret those moments of we're right around the corner. It turns out that it takes lots of years to get from easy to really, really. I don't believe in the middle of the COVID pandemic that cervical screening is, and if it's bringing a lot of people together for speculum examinations, is necessarily, or at least it's a arguably disservice if within a couple of years we can get something that's highly accurate to people. I don't know. There have been a lot of health decision analyses about the harm done by pausing. I personally, we're pausing in our program. We are not doing mass screening programs under our own right now. We're focusing on trying to get people vaccinated for COVID everywhere. That's our priority. Once we will, within 2 years, despite COVID, have something we think is reliable, accurate, and affordable, and good. So we're pausing. And I know that's controversial to say don't do anything, but that's what we've chosen.
Do you think, just to yes, please go ahead, Marc.
And I add to this, yeah, we have seen that if women that belong to not screen groups or in countries where screening was not offered systematically before, that the offer of self-samples, of cell sampling kits contributes substantially to coverage, in particular when a health professional offers the self-sampling device. We have seen in 4 studies in a randomized trial where there were home visits or in some way the health professional offered the self-sampling device directly to the women. The participation was very high.
May I have a question?
Just wait a moment, Marc, please. What I also remarked in our overview of validated tests is that there is only one validated test validated for screening that has good sensitivity, specificity, and reproducibility. That is the expert assay. That's the only one of the validated tests, and we consider now 11 validated tests, that has point of care applicability.
For self-collection and point of care.
I would point to the opportunity of new devices and tests that have been developed in the framework of COVID testing. There are a few promising tests coming up that are cheap, robust, accurate. So this is a challenge for me to validate more of these tests. Marc?
What I was going to say is you talk about increasing coverage with self-sampling. And we think that the coverage means treatment. You need to have effective treatment as recognized in the guidelines. So I'm not concerned with self-sampling now. I'm concerned with what do you do with a positive that's inexpensive and real. VIA after HPV testing is not an accurate triage method. So we need something to assist it, or you'll be mistreating some people who are HPV positive, particularly in high prevalence settings. And the industry of outpatient treatment with ablation and with LETs is not particularly well developed. So for right now, it's the entire program that I'm saying needs to be developed. And in its absence, I still feel that COVID is our main public health concern, and that's what we're trying to rally around in this particular.
Well, taking that point, I mean, I think that one of the challenges right now, of course, is weighing up priorities with elimination in the context, of course, of the pandemic. But we do know, of course, that 340,000 women lose their lives every year, of course, that we delay. Marc, just to go back to this point, I mean, I think, how would you weigh up the potential of automated visual evaluation versus models that don't require the HPV positive woman to have a visual inspection? I mean, do you expect that requirement, even in the triaging setting, will be a bit rate limiting for scaling up cervical screening, or how do you think we can develop models of care that allow that triaging to be done effectively without loss to follow up in HPV positives?
We have a symposium. We have, this takes a fair amount of time to describe accurately, but basically, I believe that in order to treat someone, you need to look at their cervix, or at least access cervix. The visual evaluation is taken at that time, combined with ablation, or whatever you're going to do. So it involves having a smartphone type device or dedicated device that would be giving a second opinion as to what should be done at that moment in the course of that action. So it doesn't add an additional visit.
Thank you very much. We only have a couple of minutes left, so I might ask Marc Arbyn to comment more, thinking about the high-income country setting now. Marc, you did present, as you said, there are a bewildering array of options for triaging once you think about all the technologies, all the models, all the thresholds, the one-time versus two-time approaches, etc. So at least 50, if not more, possible ways of going about this. How would you touched, but only briefly, on the issue of HPV vaccination. That's clearly a bit of a game changer from a prevalence point of view, at least for HPV 16-18 in countries that started vaccinating early and that now have screened and vaccinated populations overlapping. And in Australia, we are starting HPV screening at age 25. So how does vaccination and considerations about the dynamic nature of vaccinated cohorts entering screening change the triaging decision, if at all, Marc?
Yeah, we can consider the individual women who is vaccinated or not, or we can consider the background coverage. If we do not have this information for the individual woman who is coming to the doctor and is HPV positive. Yeah, we have to adopt our policies, and for screening and for triage, according to the underlying risk. I have given you the PPP plots where I have used for a very high risk group for the via triage. For the other PPP plots, we used average underlying risk. Yeah, if we have women that belong to the vaccinated age groups, yeah, the pre-test risk will be lower, and we will need for more specific triage methods. And there, cytology certainly will fail. We will find essentially low-grade lesions. So their molecular testing will be a challenge. And at the screening policy level, longer intervals, starting not before 30, maybe even postponing start to screen at 35, if you have already cohorts which are highly vaccinated, or considerations to distinguish screening and triage policies according to the HPV screening status in the country or region now.
Thank you very much. Well, I'm very much afraid that we're at time. There are many questions that unfortunately cannot be answered today, but it's been an incredibly thought-provoking and a wonderful presentation of the evidence. So I'd like to move to thank our two presenters, to refer you to the link to the WHO guidelines in the chat, where there is more evidence, more links to the actual recommendations and the evidence assessment that sits behind those recommendations. And just before we close, I'd also like to let you know about, if you don't already, about the conference this year, the IPVC conference, IPVC 2021, Toronto-based but virtual, November 15th to 19th. So please consider signing up if you haven't already for a wonderful conference where you can really see the latest evidence across public health, clinical and basic sciences tracks, so the latest in papillomavirus research. So I'd now like to thank you all, thank our participants, thank our panelists today. Thank you very much indeed. Wishing you a good morning, afternoon or evening, wherever you are. Thank you.